Uh, First of all, hello everyone. Hope you're all doing great, being fine. This is Reza Nematollah speaking, and as you may have guessed, I am the host of today's meeting. So nice to meet you all. I gotta tell you that it is the last session that we hold synchronously. So I truly hope that to this session, you've had a great experience and could find it useful. And I suppose we have some new members for this session. So just to be sure that we all know what all these are about, that what we're actually doing, it's better to reintroduce the whole thing for one more time. So this is the third series of International Online Nursing Informatics short course. The current course which we're holding right now is entitled Generating Knowledge. It will be being held for 2 months, consisting of 1 month of synchronous sessions. Like I said, it is the last session that we're holding synchronously. And after this part, we're gonna have the asynchronous part. And I guess it'll be starting a week from today. And that was it, I guess. I was told that the Dean of TUMS School of Nursing and Midwifery would like to give a speech. Is he ready or not?
No, please continue.
All right then, all right. So I want to appreciate for the time and effort they put. These people are really great in their field, and I'm not exaggerating. I truly mean it. These people are so great at the field, and it's an honor for us to have them with us. And we hope that in near future we could do something similar like this. I start with Professor Tani Hebda, and then Dr. Melody Rose, and then we have Professor Carolyn Sipes. Thank you very, very much. And also I want to thank to our professors, TUMS professors, Dr. Khatr Seizani, Associate Professor of Critical Care and Nursing Management Department and the Program Director, and also Dr. Asiya Darvish, Lecturer of Department, Moderator. So, dear attendees, like previous session, as you may know, we have a poll to launch. We launch it and we want you to answer the question. So please answer it. Is the poll launched?
Should I launch it? Okay, I will do it. Okay. It is launched, please.
It won't take much time, so please, I want everyone to answer the questions, please.
Okay. Dear attendees, I relaunched. I don't know what's the problem with poll. Someone close it. Please don't click on close poll. I relaunched it again. Okay. Please don't end the poll. Thank you. So I relaunched it. Please, all audiences, again, participate in the poll. Thank you. Thank you. 58%. Please continue. 60%, 62, 64, and 67%. I think it's okay, 66%. So I will, 69%, okay, it's fine. And now I will end the poll.
I think Dr. Nikbach is ready.
Yes, you can invite Dr. Nikbach to speak.
All right. So please welcome the Dean of TUMS Nursing, School of Nursing and Midwifery, Dr. Alireza Nikbach. Dr. Alireza Nikbach would like to announce a good news. So, Nikbach, please take your time and we are listening.
Can you see me, Mr. Dr. Darwish?
Yes, we can see your video and hear your voice. Welcome, dear Dr. Nikba.
Hello and good evening from a nice weather in Tehran. Before starting, I'd like to apologize for my blurred video. Unfortunately, my camera is broken and has some technical problems. Sorry for that. At the beginning, it gives me immense pleasure to extend a very warm welcome to all of you present here. I would also like to express my gratitude to Dr. Darwish, Asiye Darwish, who have accomplished a great work in establishing and providing the third nursing informatics online short courses. I highly appreciate her efforts and cooperation for fulfilling this value program. I would also like to express my sincere appreciation to Professors Tony Hebda, Melody Rose, and Caroline Sipes, who have cooperated with us in the fullest way. Their remarkable efforts led to enormous outcomes that we can see today. The previous courses have been widely welcomed by the audiences, and we appreciate the satisfaction of them, and we are happy to have you here again for this program, the third course of nursing informatics. I'm highly thankful of your participation here today. All these courses would have been meaningless without your attendance, really. For now, as the Dean of the School of Nursing and Midwifery of Tehran University of Medical Sciences, I'm so happy to announce, or maybe announce again, the successful approval of admission of international students in the field of nursing informatics for postgraduate master degree program for the next semester, inshallah. This is remarkable success because this field does not exist in the country and also in the universities of our neighboring countries. Dr. Asiye Darwish has prepared a pre-registration form as Google form for today, and we will start this program as soon as the registration link is prepared by TUMS International Campus. So do not forget to introduce and share this information with your friends. They might be interested in nursing informatics degree, and you provide them with this chance to apply for this degree, and they will have the opportunity to study in our School of Nursing and Midwifery related to Tehran University of Medical Sciences. I expect that this webinar will be productive. The next few hours will be enjoyable and fruitful to you all, like previous sessions. Thank you very much.
Well, thank you, Dr. Nikba, for your nice words. And Dr. Nikba, the Dean of TUMS School of Nursing and Midwifery.
Thank you.
Please welcome Dr. Melody Rose. But first of all, I want to give you a background about Dr. Melody Rose's resume. So, Dr. Melody Rose is an adjunct professor at Franklin University. She holds DNP of Nursing Informatics, MSN of Nursing Informatics, RN license, and also is a certified professional of information systems through HIMSS North America. Dr. Rose currently serves in clinical informatics at Ascension Healthcare. Previous roles have included Director of Meditate Clinical Informatics at LifePoint Hospitals, Clinical Informatics at Healthcare Corporation of America, and Nursing Supervisor at HCA. Dr. Rose has worked with Meditech, McKesson. I'm not sure that if I'm pronouncing it right. McKesson, is it so? I go with McKesson. And Cerner EHR systems. Some of her skills include enterprise-wide enterprise HIPAA, security and auditing, healthcare information technology, leadership, healthcare consulting, EMR, research, hospitals and hospital systems, healthcare management, ambulatory, CPOE, nursing HR, technology, HL7, marketing, higher education. Wow, that was quite a resume. Well, please start your lecture. We are listening.
Okay. Well, thank you very much for that great introduction. Can you guys hear me okay?
You're welcome.
All right. Let me share
we have your voice.
Okay. Let me share my screen and get the PowerPoint presentation out. What exciting news about the launch of a new MSN program in informatics. Congratulations. That's awesome. All right. Can you see the PowerPoint presentation? Yes? Thumbs up?
Yes.
Okay.
Yes.
All right, good. Okay. So thank you for the great introduction. And thank you once again for the opportunity to be part of this series of lectures. This is the fourth and the last lecture in this series. And I would like to wrap up with about an hour of lecture content and then go into a question and answer period. Most of the lecturers will be joining us for this last hour. So your questions can be aimed at any part of the lecture series. I think Dr. Sipes actually had a conflict. So if we cannot answer questions on her behalf, we will get questions to her and find the answer. Please submit your questions through the chat. You can do that now through the end of my lecture. We will have someone monitoring the chat. So you can, sure I understand. We'll now through the end of the lecture. So if we run out of time, we will find a way to get the answers to you. So let me get started with the last hour of lecture. Today, I'm going to conclude the lecture series by addressing some of the nuances of mobile health. Okay, so here are some of the objectives that I want to address today. I want to identify development and transition of Mhealth, identify technology growth that made and make Mhealth possible, discuss regulatory mechanisms for mobile devices and apps, discuss approved mobile medical devices and apps versus consumer facing, and identify populations Mhealth had, can, and will impact. So how do we get mobile health? How did we get to this point? So I think we can all agree that the world we're in right now has had a bit of a rough go over the last couple of years. Now, probably in the history of the world, there have been bad times and people went through a lot. We or they just did not know about other people's trouble because we did not communicate then the way we do now. So let's just date ourselves for a minute. And let me ask some questions, just a little bit of a reality check. If you're in a room with other people, feel free to look around and see who has their hand raised. But I want you to think about these things for a minute. Raise your hand if you remember handwriting a letter and taking it to the post office or the mailbox. How about raise your hand if you've ever listened to a sporting event or a concert on the radio because it was not broadcast on the TV. The TV makes everything easy. Raise your hand if you remember not having a TV because it was considered new technology. How about raising your hand if you remember using a wall-mounted or a desk-style rotary phone? You know, the kind of phone where you would actually put your finger in a dial and move it all the way around rather than a push-button phone. How about raising your hand if you remember a time when computers did not even exist? All right, so that's enough of the communication type of questions. My point is, our way of communicating has been completely overwhelmed and overhauled in the last 25 to 50 years, depending on how old you are. We've gone from a mostly paper to a mostly electronic world with the option of going paperless. Now, if you want to make someone feel really special, handwrite a note or a card to them and send it in the mail. The effort it takes to do this is so much greater than going to the keyboard and emailing or pulling out your phone and texting. The thing is, it doesn't give us that immediate gratification. Now, in healthcare, people seek immediate gratification because they have a need. Here's another one of those questions for my quiz. How many of you remember a house call by a doctor? Raise your hand if you ever remember having the doctor come to your house because you were sick. Now, I remember this when I was a little kid. I didn't realize the doctor made house calls only in the evening because he was probably in the office and or the hospital today. As a nurse today, I cannot imagine our doctors making house calls after the work. They're just too busy. Today, we have different options. So let's talk about some of those options. Now, when Dr. Sipes talked to you a week or so ago, she provided great definitions of telehealth. Telehealth is one of those entities that's grown and evolved and become an umbrella word that can be used for several areas. Generally, telehealth represents some type of healthcare that is done through an electronic portal from a distance. Does this sound like a fair representation? Dr. Sipes also mentioned that under telehealth, the terms telemedicine, mobile health, health mobile, Mhealth, and eHealth are also included. So let's talk about how the evolution to Mhealth arrived. Today, I'm going to focus on Mhealth or mobile health. The term Mhealth started to be used and became more defined around the year 2010. So it's fairly new. Around this time is when the smartphone technology came into the affordable range for the average person. Mobile health platform is a healthcare that relies on the smartphone, the mobile phone devices like tablets and laptops for connectivity to healthcare. Historically, a few things had to happen to get us to the point of Mhealth. First, the technology of cell phones had to move into smartphones. That was a big jump. Smartphones had to be affordable for the common population. That was another big jump. In the years prior to 2010, smartphones were developing, but the technology was expensive and not all networks supported the smartphone. By about 2006, providers were starting to buy smartphones and they wanted the hospitals to provide them. And hospitals were not going to do this. Around 2010, the internet technology had gotten to the place where smartphones could connect consistently. There were enough applications that smartphones were able to be flexible and interesting. And when I say applications, I mean besides games, and the cost was coming down. So let's add those to our list. Internet connectivity became more consistent with smartphones. Applications for smartphones were being developed and the prices were coming down. But also we realized that the investment value was also being realized in the smartphone arena. So that's what set the stage. So the use of mobile and smartphones, researching for this lecture, I read an article that was dated in 2014 that indicated in that year 40% of the United States population, the adult population, owned a smartphone, and projected that number would increase to 80% by 2020. So I wanted to check that fact out. Well, we've exceeded that prediction. The Pew Research Group indicates that in 2021, the statistic for US adult smartphone ownership was at 85%. So we've exceeded that 80% mark. The same study also indicates this population that US adults, 97% have cell phones. So there's just about 12%, 13% that still use a cell phone, but they're not smartphones. So let me go back to the stated goal of Mhealth. It's to connect electronically through technology with healthcare. This is most often done with a smartphone, but it can also be done with a tablet, laptop, and other devices. So how many of you right now are wearing a watch that can connect to the internet? I am. But smartphone technology is only the beginning of Mhealth. Like I said, the goal of Mhealth is to connect electronically or through technology with healthcare. So what other ways are there to do this? Well, we just mentioned wearable devices. I mentioned watches. What about fitness trackers that count activity? What about patient monitoring? This arena has blossomed in the last few years. Real-time monitoring or synchronous monitoring. And I'll give you the example of pacemakers, and we'll talk about that more because you don't typically think about pacemakers. But what about store and forward monitoring or asynchronous monitoring? And I'll give you the example of CPAP machines. And again, we'll talk about this in a minute. But there are so many medical devices available. And again, we'll talk about this in a minute with some exemplars. Patient telehealth appointments. And we've talked about these throughout the lecture series, but still a part of Mhealth. I actually have an app right here on my phone, and I'm not sure if how much you can see, but here's the app. It is Ascension Online Care. If I wanted to go onto this app, I could have a telehealth appointment for some time, probably within the next hour, and see a healthcare professional. So let's talk about some of the lessons that we learn with Mhealth related to COVID. So the goal with Mhealth is accessibility to healthcare through mobile and wireless technology. The original intended audience were those populations that had difficulty reaching healthcare, rural, underserved, isolated, and developing countries. One of the things of the COVID-19 pandemic did was make us all recognize that what was traditional was no longer available, and we needed a plan B. In many instances, the world went mobile via the internet. Healthcare was part of this boon. Provider office visits became telehealth visits. With the experience of the COVID lockdowns, we now recognize that many more populations can benefit from Mhealth. So I want to just expand for a minute on some of the populations that you might not think about when we talk about underserved or isolated. I suspect you all will be able to add to my examples, and I would welcome those examples so we can incorporate them into this lecture. Feel free to put a message in the chat box with examples. I think we all have good ideas of what rural health is. Way out there, nothing close, no technology around. Possibly we all understand the concept of underdeveloped countries. The technology just doesn't exist. Conditions are very poor. There are no doctors or clinics close by. But what about isolated populations? People can be isolated in the middle of big cities. People are creatures of habit. They don't like to change. So let's talk about the elderly person that lives on the 10th floor of an apartment and can no longer go up or down the stairs. The elevator, if there is one, doesn't work. That person has lived in this apartment for 50 years. So the 10th floor was not always a barrier, but now it is. How do they get to the doctor? They may find someone to go to the store for them, but going to a doctor's appointment is out of the question. What about the mom that has 3 small kids and is pregnant with the next one? She has a prenatal appointment downtown. To get there, she has to take the 3 small kids with her, Make 2 bus changes and then use the subway, which is easier. Make the appointment or stay home. I might stay home. Now, what about a new immigrant that just arrived from a different country and speaks no common language? The new immigrant may or may not have a cell phone, but it doesn't matter because the new immigrant does not know how to connect the cell phone to the internet. There was no internet or cell phones in his or her home country. Now, these are all real situations, and I suspect you can tell me of other circumstances Mhealth could potentially help or provide some type of healthcare. But let's go back through these and see how we can get Mhealth to help. The elderly tenant on the 10th floor can receive telehealth visits and be monitored remotely for certain conditions. The mom with 3 kids can have remote prenatal care for part of her pregnancy. And we hope social workers can step in and possibly provide help with the children at home. The new immigrant will have to find help with a language barrier. Once this is done, instruction and education for internet and phone use can be received, and then healthcare can be worked through. The Food and Drug Administration, known as the FDA in the United States, tells us that a mobile medical app is a software program that runs on a smartphone or other mobile communication devices, such as a tablet or an accessory to a phone or a combination of all of the above. Now, the medical app is used to communicate with devices or simply to manage health wellness. The FDA regulates all mobile medical and apps and devices. Without the certification of the FDA, an app or device cannot be sold claiming medical benefits. What makes the difference between an approved medical device and an over-the-counter or consumer-facing device or software? Well, in the United States, the FDA is the governing body that regulates the mobile medical devices, device software, and mobile medical apps. In the United Kingdom, the Medicines and Health Products Regulatory Agency is the governing body that regulates medical devices. I'm sure other countries have other agencies, but I wanted to highlight those two. Now, there is not one international organization that takes responsibility for governing mobile health devices, software, or mobile health apps for the world. North America, that is the United States and Canada, dominates the mobile app market right now with 38% of app development. Multiple countries are close behind, representing every populated continent. But the purchase of apps seems to be dominated through 2 major vendors, Google Play Store and Apple App Store. This is a growing industry. The projection for 2020 was a 31% increase in sales due to the pandemic. The fitness tracker industry revenue for 2021 was approximately $42.9 billion with a B, up from 2020 at $36.3 billion. Let me remind you, this is the consumer side, consumer facing, and it's only going to get bigger. So let's do a quick overview of what it takes to get something through the FDA. And let me tell you, this is a very high level overview. This process is not quick. There's a registration process that will cost hundreds of dollars. The registration process leads to the FDA approval process that will cost thousands of dollars. And when I give you these dollar estimates, this is just fees to the FDA. This isn't any kind of cost that is related to the research and development of the device or the app. The medical device then needs to be placed into a correct device category and follow that pathway. There are websites that will help you with this. There are instructions online. There are also many companies that will be glad to help you with this process, and they will also take part of the profits if the device or app is validated. The medical app is also governed through the FDA. The FDA website has multiple guidance pages that help the user through the steps of identifying the correct regulations and functions for the application submission. The approval process has multiple steps that includes these 7. I just highlighted these because they were somewhat tangible, going through the established registration and medical device listing, investigational device exemption requirements, labeling requirements, pre-market submission for approval clearance, quality system regulations, medical device reporting, adverse reporting, that is, and then correcting problems. Then you go through the whole process again until you get it right. So it's not an easy process, and it may take a very long time. Now let's talk about the difference between medically approved and consumer-facing devices. Medically approved devices are those devices that have been deemed necessary by your provider, and a prescription or an order written, and the device meets the needs of the order written by the provider. A consumer-facing device does not have an FDA approval and cannot be sold as a medical device or a healthcare app or a health app, but the general public can purchase these without the medical direction of an order. The FDA approval process costs thousands of dollars, months, and years of time, and probably in some cases, lots of loss and heartache when things don't go right or have to be redone. Consumer-facing products do not go through this rigorous process. They also cannot be sold with a promise of being a healthcare device or app. So let's talk about what kinds of devices and apps are available. Earlier, I talked about a pacemaker. Now, a patient would have a permanent pacemaker implanted under the skin. The pacemaker is both synchronous and asynchronously monitored at home via connectivity. My mom actually has a pacemaker, and her connectivity is monitored through the telephone lines, not the internet. The pacemaker broadcasts synchronously, but is not monitored continuously. So this drops it over into the asynchronous side. Internal automated defibrillators, same idea as a pacemaker. It's asynchronously monitored. Implanted impulse generators, and that's what my picture is on the screen. This is the same idea as this is a device that's implanted underneath the skin. My son actually has one of these in his back that innervate for him the lower back for bowel and bladder control. He actually, when he needs to adjust this, he puts I think it's a magnet over the top of the device, and then holds a monitor in his hand and dials up the amperage up or down and makes adjustment that way. Home oxygen machines, and although we don't typically think as home oxygen as a monitored product, when it's used in conjunction with CPAP machines, the results are monitored and collected. Now, CPAP machines usually have a micro SD card in them that downloads the data. So they're asynchronously monitored. You pull that card and take it to the provider at your routine appointment so that the information can be downloaded and get a readout that way. We also are seeing a rise in sleep apnea implants. So maybe CPAP machines are going to go away long term. And those would be controlled then with a mobile app that controls the implant. Then we have insulin pumps, capillary blood glucose monitoring, and the companion software that goes with that. These all provide a very close monitoring of blood sugar. Now, by no means is this a complete list, and I bet if I requested, you all could add many more prescribed medical devices. These devices communicate with data collection systems one way or another through synchronous at the moment or asynchronous stored and forward process. Wellness tracking. Let's go over to the non-prescription or consumer-facing side of healthcare and talk about those non-medical devices that are available as health aids over the counter. How many of you are wearing a watch or a fitness tracker on your wrist that measures or monitors your activity? Fitness trackers are most commonly worn on the wrist, but they can also be on a clip-on device, earpiece, smart fabric. I have a ring that I wear besides my wristwatch. And by the way, if you wear two of them, for me, it doesn't make me exercise any more frequently. I was hoping that was going to be the case, but no. So what is the draw with wearing this type of a wearable or or an app. Well, I don't have to go to the gym because I can exercise where I am. I can take advantage, if you're a busy person, I can take advantage of what I'm doing. So if I'm walking the halls at the hospital, I can take credit for that as an exercise. If I get a moment, I can go outside and take a lap around the hospital, and I get credit for that. So I can do at the moment workouts. Sometimes that's hard to get if you sit in an office all day. On the marketing side of the fence, while the consumer is looking at the app, the vendors can flash pictures of fancy shoes or workout gear, and that makes you want to go out and buy their product. Now, I want to draw attention to the graphic that I've got on the screen with this, because this is an actual picture of my Aura app that came off of my phone. And this is for April 30th. That was last Saturday. And it's just a little visual. You can see that I walked over 12,000 steps. I'm rather proud of that. Pat myself on the back here. I walked what was equivalent to 6.3 miles, and I got a score of 88. Note to self, I've never scored 100, so I'm pretty proud of 88. But this is just a taste of what the app actually looks like. There's multiple screens that go with it, but this is the activity screen. Okay. Let's talk about some of the statistics for wellness tracking. This industry is huge. This is a consumer-facing app and device industry. 61% of the fitness tracker sales are made online, which is kind of ironic that you would measure your activity and order something that's delivered to you. Anyway, 39% are made in actual stores where you actually have to walk in and exercise to get it. Women are more likely to purchase and use a wellness tracker than men are. 42% of the global revenue in this field comes from North America. Asia is predicted and identified to be the next fastest growing market, and that projection range is identified as 2021 to 2028. By device, the breakdown is as follows: 43% fitness bands, 28% smartwatches, 12% smart clothing, 11% smart glasses. And I have to admit, I had to look and find out what smart glasses, as in eyeglasses, were. I had not actually seen these. And then 2% other options. And I think my Aura Ring fits into that other option. But I want to continue with some other statistics. And this kind of goes back to my first week lecture when I talked about underserved populations. So when we talk about income, upper income households use fitness and wellness trackers a little bit more than the lower income. So half of upper income households are inclined to use them, where only 25% of lower income households use them. Geographic locations. I don't think this is going to surprise anyone. Cities and suburban areas or urban areas have a 35% greater usage, 30% for rural areas. And this more than likely is a connectivity issue. But what surprised me was the race and ethnicity breakout. Hispanic adults use fitness trackers the most, 26%. Black adults come in second at 23%, and white adults are least likely at 22%. So what kind of apps are available besides the Fitbit and the Apple Watch as being two of the fitness trackers? And by the way, did you know you can attach the Fitbit to your dog's collar and send them out in the backyard and get all kinds of points for that? Not that I've ever done that. How about a ring? I've talked about my Aura Ring, and I'll give you an example of that here in a minute. I wear the Aura Ring. I've had it for a couple of years. It tracks my activity, my heart rate, sleep cycles, body temperature. It transmits data to a cloud-based website that I can monitor. So this device is also with a mobile app and my computer app. So it allows reporting. I can go in two places. I also agree to share data. and I've participated in unique studies. One such study was in the very beginning of the months of COVID-19 pandemic. What about over-the-counter heart monitoring? The Apple Watch can do a 2-lead cardiac rhythm. Now there are devices that you put your fingertips on, 2 from each hand. Cardio Mobile is one of those. And I've got a picture of just a EKG recording device. Cardio Mobile is a brand name, but you can get an instant reading of a 2-lead heart rhythm. Now the disclaimer here is that you should always consult your provider, but these are over-the-counter devices. The device will tell you if your heart rate is normal, slow, fast, or irregular. Now, the Apple Watch will also capture a 3-second heart monitor wave and record it. So if you're knowledgeable about cardiac rhythms, you can also identify PVCs or atrial fib and or atrial flutter. But what about hearing aids? The technology has really improved with hearing aids. If you go to a doctor, you can get a really expensive pair of hearing aids that fit the kind of hearing impairment you have. If you go to Amazon, you can buy a set of hearing aids for $100 and see if they help. Now, these seem to be extremes. There are many options in between, and I admit that the $100 Amazon hearing aids are probably simple amplification devices. But hearing aids are items that tend to get lost, so inexpensive replacements sometimes work well when there are not thousands of dollars to spend for replacements. Also, there are companies such as Lively that offer provider audiology support and are FDA approved, all online. Even a simple thermometer has come a long way. We used to use the glass thermometers that were filled with mercury to measure temperatures. Now they're all electric, and you can buy one for as little as $10. We have thermometers that measure temperature by infrared technology, providing the no-touch temperatures. These were well represented at the height of COVID, and they also start for about $10. Again, there are many more over-the-counter, non-prescription, consumer-facing medical devices that are meant to improve healthcare. Work needs to be done to review with a critical eye. I want to talk specifically about mobile application or mobile app. And some of the medical devices I've mentioned connect to a mobile app, some do not. Certainly a pacemaker is not going to be governed by a mobile app, but my technology ring or the fitness watch is. Do any of you check your phone app throughout the day to see how many steps you've taken or how many steps you need to take to maintain a certain level of activity? I know I look at my Aura app in the middle of the day to see how I slept the night before. Sometimes I might be looking for an explanation of why I'm trying to stay awake during a meeting. Now, I say that in jest, but to be clear, we know that looking at one slice of a picture and doing a self-interpretation is not a healthy thing to do, right? When the Apple Watch started presenting heart waves, a cardiologist acquaintance told me many of his patients started flocking to his office with self-diagnosed arrhythmias. So the word of caution is that mobile apps are to be used with responsibility and common sense. Mobile apps are not connected to a medical device. This is a big medical industry and was created and increasing by demand. Thank you, COVID-19. One of the things that COVID-19 pandemic did was make us all recognize that traditional was no longer available. Provider office visits became telehealth visits, and any type of hospitalization became predicated by pre-registration and screening, which became a remote event so that it cut down on contact time. The only things that could not be done were actual hands-on events and that were considered urgent or emergent. Now, another outcome of COVID-19 pandemic was recognition and awareness of the need for mental health care, regardless of if the need was there before the pandemic or a result of the pandemic. Mobile telehealth apps are now being used to treat certain types of mental and behavioral health issues. So this is a growing area of telehealth, and it's focused on psych, mental health, and behavioral health. COVID-19 pandemic identified the need for psych telehealth and also created the need for psych telehealth. With any telehealth app, it's important to research and make sure the choice is best for the patient or individual. Things to look for and consider. Does the app meet appropriate federal and or industry regulations? Does the app use or is supported by evidence-based research? Is there a third-party certification? Are there any legal or regulatory actions settled or outstanding against the vendor? And does the vendor ensure social equity and diversity? Not all psych, mental, behavioral health diagnoses can be treated through telehealth. However, telehealth individual assessments can be done for initial anxiety and depression diagnoses. From here, a plan of care can be identified and individualized to the patient. Treatment of substance use disorder can also be done through telehealth, as well as prescription monitoring and refills. The flexibility of telehealth includes the need to bring the patient into a brick and mortar facility if deemed necessary, or follow in the telehealth capacity. This falls upon that telehealth practitioner and their skills of assessment and evaluation. Both the patient client and the telehealth professional will need broadband internet access for successful sessions. What about other types of mobile apps? Has anyone used a diet or an activity app? There are apps to help people stop or reduce habits such as tobacco use. Now let's throw in social media, not as a mobile app, but as an influencing factor. The power of social media is exponential. Social media has the ability to change the course of the world. The persuasion of social media can direct good tools to be avoided and bad tools to be the best thing in the world. So how do we keep that from happening? Who governs the content and results of mobile applications relating to healthcare? Well, I go back to the process of getting a health wellness device or app through the FDA or Medicines and Healthcare Products Regulatory Agency, the agency of the UK approval, or any other country's agency. And what if they're not approved? If they are not approved, they still get marketed by Google and Apple. It just is marketed as a different style of app. This becomes a consumer beware type of situation. It almost seems like Google and Apple become the gatekeeper here. This is where nursing can have an influence in Mhealth and guide the patient to the correct and away from the incorrect wellness device and apps. There are more than 350,000 mobile wellness apps available. This is an astounding number to me, but clearly the audience is out there. How does the owner of the app keep the audience engaged? We want healthcare apps to be successful for a variety of reasons, but two in particular. We want the patient, the client, the consumer to benefit somehow from using the app. We also want the collected data to be reliable data from the use of the app, so the data can be evaluated, reinfused into the app, and the app made better. So what is the ask with a mobile health app? In many cases, it's simply to document data. Here is an example. Through COVID time, the company I work for requested that I use an app to document my symptoms or lack of every morning I arrive to work. If I were working remote, I did not have to use the app, but if on campus, I had to use the app. The motivation was getting paid. I had no other reason to use this app other than my employer telling me to do this. Now, I'm highly motivated when my employer ties something like this to my paycheck, so I complied. Every morning, I signed into the app, answered the questions about my potential COVID symptoms, and then I entered my temperature. Once my employer told me the data recordings were no longer required, I stopped. There was nothing personal in this for me. More than that, the app was hard to get to. It did not load an icon onto my phone. I really do not appreciate forced compliance without knowing what the long-term goal of the data collection process was. Now, comparing this to the research study that I signed up for, I was a willing participant. This is through my Aura Ring. that asked virtually the same questions on a daily basis. And I was also sad when my participation in this ended. There were a couple of differences. The voluntary participation, like I said, was through my Aura Ring. I was sent an email reminder daily to participate that linked to the questions, so I didn't have to go find it. My temperature was monitored through the ring. I did not have to physically take it. And I was frequently sent updates about the progress of the study. So I felt like I was a participant in one situation and that I was being bullied in the other, but the information collected was almost identical. So things to consider about the consumer. Consider the market, the consumer, the patient the app will be aimed at. What is the functional ability of the population? What's the work time required to participate? Use of passive monitors. Think about the fitness tracker, or in my case, the Aura Ring that actually monitored my temperature. And also think of the privacy concerns. Think about the use of push alerts or automated reminders. And please don't go overboard with this, because always remember alert fatigue, maybe one reminder a day. What's the personal motivation for the app for the consumer? What is the goal of the participant? Are they managing a health condition? Could they be looking for something like pain reduction? Possibly it's something as simple as an increase of exercise. Potentially, they simply want to participate in a new product or study for COVID statistics. That's what I was looking for. People are more likely to participate and continue to participate if they have a strong motivation. Motivational reasons would include feedback on their input. So seeing the responses in the data as results, seeing the responses addressed in product development, seeing results in the study along the way, participation results. Social media can help with this. Personal contacts at predetermined points, check-ins, courtesy calls, emails, support staff available for feedback, seeing end results of the study, published results. I was very happy to read the journal article that came out in the first, as a result of the study that I was in with the Aura Ring. Now, I have mixed emotion about this slide. This is titled Focus on Specific Populations, but it was originally focused on older adults, because that's a little bit too close to home. Actually defining an older adult, I might fit into that category. But it's difficult to define that. At what age does one come to the crossroads of needing help navigating the activities of life when it comes to technology? That can vary. Adults in their 50s and 60s remember a time without readily available technology. They've also lived through those painful development years of Radio Shack computers, dial-up modems, mobile phones that were not so mobile, and a variety of infrastructure changes that have gone from refrigerator-sized equipment to cell phone-sized equipment. Yet, we're the generation that's labeled the immigrant generation, and the younger generations, those born after 1985 and have never lived the history, are considered native generations to technology. Regardless of the labels, the fact is we need to identify the needs of an older or less technology-oriented population of people and work towards finding what works best for them. App design must be aimed at the lifestyle of the targeted population. Connectivity must be available. The app needs to be easy to use, tailored to the functional ability of the participant, and support must be available. So here's 6 quality indicators to look for. How easy is the product to learn? How fast can the user perform the task after learning? How memorable is the task? In other words, how long will it take me to memorize that? How are errors identified and accommodated for? Do users feel satisfied when using the system? And what is the utility or functionality of the system? Now, no lecture is going to be complete if we don't talk a little bit about ethics and data storage and collection. They're kind of intertwined. So let me go there. The ethical collection of data has been a very long and well-shaped road. We've made a lot of mistakes here in the past. After many unethical events of research and data collection, the United States now identifies the Office of Human Research Protections as part of the United States Department of Health and Human Services. Healthcare data that is collected from the electronic health record, the EHR, is protected by the Health Insurance Portability and Accountability Act. You know, this is HIPAA. A consent for data use must be signed by the patient, or data must be de-identified before it's used. Research studies must be submitted and research studies must be submitted to an institutional review board, an IRB, for complete vetting to make sure that the rights, welfare, and well-being of all human subjects involved in the research are protected. Data returned from the research study must be stored in a safe and secure manner. Long-term management needs to be balanced with preservation and sustainability of the database. The Office of Extramural Research, Education, and Priority Populations governs the long-term storage of health databases. Most research projects have long-term data storage strategy written into the protocol of the research. All right, let's talk about payment for just a minute. Prior to COVID-19 pandemic, Medicare would only pay for telehealth on a limited basis. Although the value of telehealth was beginning to be recognized and expanded payment, the pandemic broke through any remaining barriers. The emergency 1135 waiver put in place on March 6th, 2020 by President Trump in response to the COVID-19 pandemic expanded telehealth, hoping to ensure access to healthcare via telehealth. As the pandemic either continues or resides, these state extended coverage benefits will need to be monitored. And I will note that later in 2020, the Trump administration actually finalized permanent expansion of Medicare telehealth services. So here are some terms of telehealth. Providers must use interactive audio and video telecommunications that permits real-time communications between distant site and patient at home. Practitioners can be reimbursed for telehealth, and you need to refer to individual states, but they include physicians, nurse practitioners, physician assistants, nurse midwives, certified nurse anesthetists, clinical psychologists, clinical social workers, registered dietitians, nutrition professionals. During the COVID-19 public health emergency, payment was made at the same rate, or payment is made at the same rate as regular in-person visits. And I will also note that April 12th of this year, just a little over a month ago, the public health emergency was renewed in the United States, and each renewal lasts for 90 days. So the last slide I have for you are resources for healthcare professionals. There are many online resources for telehealth and Mhealth, but most are aimed at the consumer. If the professional reads the consumer-based information, there will be a gain of information, but not a direct knowledge base of how to. But not to worry, because the telehealth.hhs.gov website has a specific section of resources for the provider. The website seems to be current, and it starts with a section that's labeled Getting Started with Telehealth. What a great place. The website progresses through workflow, equipment, and preparing patients, discussions related to COVID-19 and the current pandemic in multiple ways. It also has legal considerations and provides a variety of best practice guides. So for the healthcare provider that is or will be branching into telehealth, this seems like a good place to start for basic telehealth resources. So what kind of questions can I answer for you? And I will put up my list of references here.
Thank you so much, dear Dr. Rose. We will wait for the questions in the chat box and some others can raise their hand. But before that, I think Mr. Nematullah, he wants to ask somebody to speak. Thank you.
Hello again, Dr. Rose. It was so perfect. Thank you for your nice lecture. And dear attendees, if you have any questions, you can ask right now or what?
Did you want to do the post questions?
We have Dr. Khater Seydani to speak. So for now, right, Dr. Darvish?
Yes, supposed to.
So we may put this Q&A for later. For now, we have Dr. Khater Seydani, right?
Yes, yes.
We have Dr.
Speak.
Khater Seydani to share a couple of words with you. So,
Hello.
Yes, she's here. Hello, we can hear you.
Can you hear me? Thank you
Yes,
very much.
yes, Doctor, we have your voice. We have your voice clearly.
Thank you. Hello. First of all, I want to say thank you to dear Dr. Rose for her informative speech, and greeting and respect to the other participants and colleagues. It's my pleasure to participate in the last session of this short course, and I would like to congratulate the professional and capable team, especially the visiting professors, dear Dr. Hebda, Dr. Rose, and Dr. Sipes, and also Dr. Bilson that helped us in running and launching these short courses, and our internal professors, executive team, and dear students who, as a professional team, organized these excellent short courses. The excellent quality of these short courses, the positive feedbacks received from the participants, and the efforts of the officials fortunately led to the approval of the Nursing Informatics Master Degree Program for international audiences. And in my opinion, this is a very valuable achievement that could not have been achieved without this excellent teamwork. I'm really excited for that, and I'm really happy for this remarkable success that was the ideal goal and maybe a kind of dream in the first session of these courses, short courses, and now becomes a reality. And I hope we can run this master degree program as a full online course by the end of this year. I'm sure that this master degree will be launched soon with the non-stop support of the university and faculty officials and this professional team, as well as enjoying our keen audiences. So I hope it will be a turning point in making our regional nurses familiar with informatics, sciences, and finally, I hope our patients will benefit from this, new and necessary kind of science. Thank you very much for giving me this opportunity. And again, thank you, Dr. Rose. And also, I should emphasize that without the non-stop, efforts of Dr. Darvish and sincere support from Dr. Nikbacht and also Dr. Manikian, the new Vice Dean for International Affairs in our nursing and midwifery school, we couldn't have this, significant achievement. And I say my greetings and thanks to all of them. Thank you.
Dr. Seydani, and is there anybody else to speak to the audiences?
Yes, Dr. Azadi also, yes, she wants to speak. Please ask her.
So, please welcome Dr. Azadi. She would like to speak to the attendees. Dr. Azadi, you can start.
Thank you, Dr. Darvish, and big thanks to Professor Hebda, Professor Sipes, and Dr. Rose for this wonderful course we had and for their informative presentations. Indeed, telehealth nursing, or as it is called, telenursing, is already changing our healthcare system. In many hospitals and healthcare systems in many parts of the world, it has been already deployed. And in some other countries like Iran, it's being implemented gradually. So in this wonderful short course, we have discussed some important aspects of telenursing and its technology solutions, its different services and its advantages, and also some of its challenges and limitations. I'm not going to get through that now. However, a very important issue I just wanted to quickly emphasize again here is the ethical aspects of deploying technology into healthcare services. Dr. Rose also addressed some aspects of it, like patient engagement issues and data collection issues. Matters such as patient data, privacy and security, equity and equality, access to technology like internet and smartphones, beliefs and attitudes regarding trust and distrust in technology, insurance issues, the risk of reduced continuity of care. So these are just some important aspects of maybe telehealth services generally to consider. So what aspects to consider to make it a convenient and quality experience for the patients and for their families? We actually need to also think and understand what makes a telehealth service ethical or maybe unethical. So I believe this is a very fundamental aspect of telenursing. And in fact, not just telenursing, every type of telehealth services to think about before initiating any technology solutions. Perhaps in future courses, it's also an aspect we need to discuss more. In the end, I would like to take the chance and say a huge thank you to the hard-working team of academic staff and students of TUMS School of Nursing and Midwifery, led by Dr. Darvish, for providing us with this great opportunity to learn from each other. It was also great news to hear that now the school can offer the master program for nursing informatics for the international students. It's a great achievement, so thank you for that. Congratulations. And by the way, Dr. Rose, I remembered some of those anecdotes you were mentioning, but I was afraid if I raised my hand, you'd be able to guess my age, so I didn't. Okay, over to you, Dr. Darvish. Thank you.
Thank you so much, Dr. Nikbakht, Dr. Seilani, and Dr. Azadi. Thank you.
I guess it's time for Q&A time, question and answer time. So please, if any one of you has any question, please share with us, and our dear professor here will answer your question.
Yes, we have some questions in the chat box.
Let me see. I might have missed them.
One is from Wahab Osman. Is written, Dr. Rose, kindly recommend universities with PhD in nursing informatics for me. Not a question. I think he just thanks.
I cannot find it. I'm sorry. I cannot find it.
Yes, another is from Wahab Osman. As a clinical nurse, how do you balance recommending Mhealth apps or devices to patients and conflict of interest? I ask, please resend your questions, because there are some other messages. So
I reread the question. As a clinical nurse, this is the question we have. As a clinical nurse, how do you balance recommending Mhealth apps or devices to patients and conflict of interest?
Okay, so it's a great question. And part of it is simply getting to know your patient, being engaged in your patient, and knowing what they're doing. So the dependency is having a relationship with the patient, whether it's being an office nurse, a hospital nurse, having the patient come in, but you have to know the patient and see what they're doing and develop the rapport to see how they're communicating. It also, you know, it's not necessarily limited to a professional relationship. In my home life, I have many, many people that come to me and say, hey, you know, I've got this ache, I've got this pain, or I've got a problem. What do I do about it? And I have the opportunity to see that they're bringing me, you know, I've got this app on my phone. And I'll look at it and say, you know, that might not be the best thing in the world, but you have to establish a line of communication. Now, what that backs up to is you as a clinician need to be familiar with what's out there. So if you don't know, then you have to have a community of practice. And I think we've talked about this at some point in some of these lectures. You have to be tied in with what's new, what's current, and what's happening. So if you don't know what the current healthcare apps are, you need to know someone that does. Be able to refer them to a provider's office that uses telehealth, refer them back to their own physician or provider. You have to go out and find the information yourself. It goes back to looking at websites, knowing what is FDA approved, what isn't, knowing social media. And I swear that social media is going to be the bane of our existence when it talks about sending people to the wrong place and doing the wrong things, because it has such an influence over our children and telling them to do not the best things for themselves. Does that make sense? Did that answer the question?
Indeed, you did. Any other questions? If you have any question, you can ask it right now. I will read it for Dr. Rose.
Let me address this recommendation for a PhD in nursing informatics.
Yeah.
So informatics, PhD, DNP, you fit to what you want to do in life. PhD is more getting into the weeds and actually doing the research. DNP is applying the research in a clinical position. So decide what you want. Then you simply go out and do a research or a search for the universities and what fits your need. There are many of them out there. You have to decide if you want to go on campus or if you want it to be online. And then you find out what fits your budget. It's as simple as that. There are many offerings. If you're an international student, that might limit you some. You know, I just had a friend that I found out this week finished her DNP and she is a PhD. So she is a double doctor and I'm very proud of her. So there are many programs that come up every day. I think Franklin University, my place that I teach for here in the United States, just started their DNP program. Not every program, PhD or DNP, is going to do offer the informatics level at the doctorate level. So you just have to research and find what you're looking for. It's as simple as that.
Thank you. I think our active attendees can speak. We would appreciate, and also we will be happy if have some actually speaking from Professor Hebda. If she wants to speak, we will be happy.
I'm so sorry for interrupting you. We have a new question. I read it for Dr. Rose, if you mind. This is the question. She's asked, how do you maintain a sense of humanity or improvise for the physical touch of nursing and nursing informatics or telenursing kind of nursing?
It's a great question. Let me flip over to the patient side of this. And I can relate to this because of my mother, who is 86 now, I believe, and has multiple diagnoses of different things. But we do telehealth visits with her, and we also do in the office visits with her. So telehealth is a wonderful convenience because bundling her up and putting her in the car and actually transporting her to a physician or a provider is a lot of work. But being able to do a telehealth call with her in her home is wonderful because it still gets the job done. But there is a lack of the touchy-feely, you have been seen, you have been heard. And when we close the computer with telehealth, she always looks at me and says, who was that? What did they do for me? I don't think they actually did anything for me. So you have to weigh the benefits of that. In her generation, she doesn't necessarily appreciate telehealth. So telehealth may not be the best application for someone of that generation. My generation, your generation, that appreciates the aspect of telehealth and the convenience and recognizes the value of it, that's a different story. But keeping the humanity side of it, I think there's a mixture of telehealth and still going into the office to get the face contact, the eye contact, and knowing that you're being heard is very important. I also, in my personal life, I also am using my patient portal and sending messages back and forth to my doctor so that I know I'm being heard. So it has become a two-way street where before you just went into the office and that was it. Now it's a two-way street. The patient is expected to be in full communication with the provider. So that's my take on it.
And this is Dr. Hebda. I would just say you can still establish a sense of caring, even if you're not there to physically touch that person. So you may actually have a richer visit by establishing a sense of connection, even though you're not face to face in the same room.
All right. So I think we're done with this part, and now, if I'm not mistaken, it's time to take a group photo, right, Dr. Darvish?
Yes, I thank you, Dr. and Professor Hebda. I also want to say, think about the benefits of communicating more through telenursing and remote nursing, and look at it as a complementary to face-to-face nursing, not instead of face-to-face nursing. I think it can help you to mention some benefits and some problems we have in telenursing. We can have mix of both, and we can help people from a distance. As in Iran also, we have some mobile applications people can just use them free, and some of them maybe they need to pay only a little, and they are so helpful. We have different apps for actually consultation for nurses and diabetes, or about many different programs. It is developed in Iran also. There's another question.
Thank you for your answer. Shall we take a group photo or not?
There is another question. Let's please, Dr. Rose, read it.
Let me see it.
From Sadullah.
One of our attendees has asked that is master degree free or not? Free for what?
Before that.
Before, let me see.
In our country, we don't have infrastructures of nursing informatics.
Yeah, in our country,
yes,
I'll read it for Dr. Rose. The question: in our country, we don't have infrastructures of nursing informatics. Even there is no medical informatics, and I think it takes time to create a plan for future in our country. I'm wondering, where is the question? I didn't get it. This dear attendee just mentioned about his opinion.
No, I think he's asking their sponsorship and stakeholder in your country to transfer experiences and some available experiences and applications in telehealth and nursing health and encouragement in our country. So in any country, there's going to have, in order to make telehealth, telenursing work, you've got to have the policies and procedures in place. In the United States, in the UK, in other countries, we're a little bit further down the road in that we've got some of the structures in place, and they're a great place to start. There's no reason to recreate the wheel. Grab those structures, put the policies and procedures in place, and build on that. Take what works for you, throw away what doesn't work for you, and build on that and go forward. It shouldn't take you as long to get those in place so that you can stand up a system and go forward. I hope that helps. I hope I'm interpreting that question right. Build on our experiences and don't make our mistakes. Go forward and do it better.
Thank you. I also think they can start with reading and studying some guidelines, telenursing guidelines, and which competencies nurses should have, and start with education. I think the basic for improving is education. The basic part is education. And if you try to teach nurses how they can offer their services by distance, and what are the regulations, and support them and start it, then I think it will go on, and slowly people also will be interested.
Thank you for your answers. And I'm afraid if I say take a group photo and then another question pops in. So
I think we have poll also, and also before that, again, we ask attendees, some of them can speak. Just
right.
writing in the chat box doesn't make sense.
Yeah, of course. So, dear attendees, we have to launch. Please answer it. Please launch the poll, and our attendees could answer the questions.
There is another question also here. Can we use telehealth for prevention as we can use it for treatment aims? I think Dr. Rose answered it, yes?
Yes, most definitely. That's a great use of telehealth for routine checkups and preventative health. And that's a great use of telenursing. In the United States, especially, we run short of doctoral trained providers, and it's nursing that picks up the slack, and putting nursing in the preventative roles so that we can head off diseases and concentrate on preventative health and proactive health is a great use of telehealth. So I would give that a big thumbs up. Yes.
Yes. And for prevention of cancer and behaviors.
Yes, and making sure people are meeting their screening dates and getting proactive exams and things like that, especially in kids. Make sure they're getting vaccines in the right places that at the right times and meeting those developmental marks and the same for elderly too. So I mean it's just good preventative health. So yes, nursing, yes.
And also self-care, because self-care is the most important for preventing diseases.
Text pictures. Okay, so this question is bridging over into the privacy, talking about texting and pictures, efforts and patient is not happening in telehealth. Okay, so that goes into the ethics side, and this is a problem. So first of all, texting is probably something that needs to be discouraged because there is not a trackable way to communicate. So instead of text, email, so that you've got a record of it. Unless you just go around and take pictures of your screen of texts, and that's probably not going to be a good practice. There are programs for pictures that we can put into medical records. As a matter of fact, that came up this week at my work. How can we insert pictures? Because that is starting to become a vital portion of the medical record. You have someone that comes in with a wound. You need to take a picture of that and put that in the medical record, but that is ethics driven. So you need to make sure you've got consent and that it stays private. But if you can see a wound through telehealth, wouldn't that be great, so that the patient doesn't actually have to come in, but it has to be a detailed picture so that you can actually stage that wound and treat it appropriately. If it's too far gone, it's like maybe you need to come in and see someone rather than stay at home. So, but it does have to be secured and private and consent driven. Is this because there's no
I also believe, same as Dr. Rose, and that communication must be through secure application and security must be maintained, not through, for example, Telegram, WhatsApp, and even email may be forwarded to others. It's possible. So this communication and who have access to the information, these are regulations that we talked about. And there are standards and regulations, but because people doesn't know that, many countries, nurses or people, communities, they don't know about the regulations, so they use telephone or some unsecure tools for communication.
Yeah, we've got to get away from the unsecure communication, because that's where our privacy breaches come through. And the next message that came through is the tension between nursing and the tech side of things. Those barriers, those walls will come down. That tension was there originally when in the United States, when technology came in. Those barriers will eventually come down. Just be patient and be empathetic, but make sure you follow policies and procedures. And those policies and procedures need to be set before you can go forward, so that you have something to go back on when you follow them. Like, this is the way we do things. This is policy-based, policy-driven.
And also there are two more questions.
Yeah, I was about to ask them. We have this question. Can we integrate nursing theories in telenursing to improve the soul and art of nursing?
I'm sure you can. That is an area. Tony, are you out there? Do you want to speak to this?
Thank you. There are so many different theories. In fact, there is a caring theory, and I can't remember, I'm sorry, the particular person behind it. I want to say Locin. It's perhaps Locsin, that is an evolution of a theory of caring. But we have many, many theories that support technology applications in healthcare that have to do with Rogers' theory of diffusion of innovation, early adopters versus late adopters, people that will adapt technology first, use it well, help others. And of course, you can go back to the grand theories in terms of Gene Watson in caring and meeting basic needs, and all of the traditional big names in theory. And then you also have all of the work that's been done to develop the standardized terminology, building off of the theorist. I hope that helps.
And there probably would be room for a brand new theory that is specifically aimed at telenursing.
Yes. We also have work that was done by Susan Matney, who's written and presented extensively on standardized terminologies, but she has a wisdom in action theory that actually I believe is going to be in our revised scope and standards of practice for nursing informatics. That should be out this month.
Very nice. Thank you so much. Very informative.
78%, almost 80% of participants has answered the poll, so I think it's time to close it. Most of them have done with the answer D, all of the answers.
Some of them said thank you in the chat box. And Mr. Dara or Dr. Dara, I think, asked more information about our MSc program. Yes, we will send by email within next month. Thank you for pre-registration. We will find your email in that form, and then we will inform you more about our Master of Science. Okay, I
So,
think you
Dr.
can
Darvish,
end the poll because 80% participated.
yeah, the poll has
Yes, it
already
is
been ended.
closed. Yes, thank you. Okay, if
So,
anyone wants to speak, this is the last minutes. Please, our active attendees, if you want to speak, we will appreciate it. Otherwise, we should just take a group photo and end the session. So we have more, about 10 minutes or 15 minutes more. If anyone wants to speak, please raise your hand. These are
please
the
raise
last
your hand that you
minutes.
can turn on your voice. I'm sorry, not camera. Turn on your microphone, actually. Turn on your microphone to speak with
Yes, there
Dr.
is Mahdi Khani. Yes, wants to speak. Would you please unmute?
Hi, everybody.
Yes, you can speak.
First of all, I ask you really, my English not perfect because I'm living in Italy and I take Italian, so if you have some error, I apologize before. So I wanted to talk about my experience about my PhD courses. So when I had a research about self-care in breast cancers women, and one of my findings was a qualitative research. So what have I found? It was the lack of the information, and it was really a big problem because there are a lot of other problems that connect to that. Okay, and I worked as a nurse, and be honest, sometimes you lost a lot of things while you are doing these things in the hospital because maybe there's not the good quantity of the staffs, maybe a lot of problems if everybody work in this this environment know what I'm talking about. So after doing this research, because when you do a qualitative research, and I did that even in Iran, so I had in the 2 countries, and I had the possibility to see the stuffs in different culture, different environment, different health care even. So I find if the patient has enough information for the process of their therapy or even nutrition, even sport, everything, maybe we can resolve a lot of their problems in this this difficult moment. So it's like 1 year I am working on a project. I want to propose it if I could do it as a postdoc project. So about the crane applications for this kind of the patients, for self-care of this kind of the patient, and it's a kind of the mobile health cares, so that you can help these patients to know how they should coping with this this disease, or their problems. In this situation, they have a lot of problems and they don't have any answer. And maybe a lot of time we don't have enough time to give them enough time to respond their needs. And I find it very highly, it was very highlight this problem in Iran, because in Iran, healthcare is very different. In Italy, a patient come to the doctor office and like half an hour, like my colleague in Iran, they know what I'm talking about. In Iran, no, it's not like that. If one patient entered the doctor office, the other one is the behind of the door, the other one is knock, the other one says, yeah, I want to only show my analysis. And there's very confusing situation, and the patient, they don't have really time to ask the questions, the doctor or the nurses, they don't have time to respond. So I really believe Mhealth can help patients a lot, but not only patients, but also nurses, doctors, or every medical science. I don't know. I don't know if somebody could understand my bad English.
Your English is very good. So I was listening.
My husband is American.
I was listening intently, and you're right that oftentimes there never seems to be enough time to listen to patients with very grave concerns. As I listen to you, I know that there are a number of support groups that are available on social media. Of course, one also needs to balance the support groups with the possibility for information that may be less than accurate. But many people derive great comfort from the support groups. And I know that quite a few years ago, when I had students, basic baccalaureate students in a pediatric course, we had many children that had extremely rare conditions, and the patients' families would educate the staff because their cases were so rare, and they used much of the information that they found by networking with other family members that had a similarly affected child. So it's not always the perfect answer, but for some people it is a partial answer. And I think that with healthcare professionals, perhaps having a presence, being available maybe on a consultation basis, or providing informative newsletters or whatever on these sites, we can further help many of our people.
Yeah, but what I saw actually in Iran, there is no consultant groups. And the patient, they always connected together to create these groups. They always wanted to know the other ones what they did, but everybody has a different response to the therapy or to the situation. So sometimes they were very confused, because if you have some application, like there is a 10-way suggestion to cope this kind of the problem, maybe they are in a very good psychology situation, because it's a very big impact of the of this kind of the problems is the psychologist impact, and they have really they are in very bad situation. They don't understand what they don't do. They don't have enough information. And I repeat that it's not only about Iran, because I did the same research in Italy, and the results was quite like almost the same. And I wonder about that two different countries with two different cultures, they have the same problem. And I don't know, maybe I can do something in the future with this idea. But
I hope. It's very nice. Thank you. Thank you for sharing your experience.
You're welcome. You're welcome. Thank you, all of you, to listening to me.
Thank you. Thank you, Professor Saiz, Professor Hebda, as this director of this team, and her colleagues, distinguished lecturers and professors from different universities. They helped and they shared their knowledge here in these free courses. Thank you so much. Okay, if anyone else wants to speak? No one? And no any other question? So I think, Mr. Nematullah, we can end the session. With many thanks to all attendees and also professors. Thank you so much.
Picture?
And we have 1 month more also. We have another 1 month for asynchronous program, and we are in touch with attendees by email and our WhatsApp group. And we will send them a link for survey after 2 weeks. So on June 16, this 2-month program will completely finish, and then certificates will be prepared and sent by email. Okay, someone wants to speak. Parveen Delavari. And another, yes, only Parveen Delavari. Would you please open her voice or unmute her? Parveen Delavari. Our dear Appraise to Raise team supports our technical. Please unmute Dr. Delavari. Dear Mrs. Sadeghi, would you please?
I'm trying to mute her, but it's not working. I don't know why, but it's not working. I'm trying.
I sent her the request, and she has to accept the request.
Oh, then.
Okay. Dr. Delavari, would you please accept the request for unmute? Then you can speak. If you are interested to speak, please open your microphone and accept the request. Can you speak, Dr. Delavari? Okay, I think there is any problem with her microphone. Yes, we can see your video, Dr. Delavari.
Her camera, but we don't have your voice, Dr. Delavari. If you hear us, we've sent you a request to be unmuted. Just please accept that request, because we cannot hear you. We don't have your voice. Check your screen. There must be a request to be accepted. You're still on mute. If you have problem with speaking, then it doesn't matter at all. You can write down your question on the chat.
Your microphone is not working. We can't hear you.
Dr. Delavari, could you please just write down your question on the chat box? I will read it for you.
Sorry, we don't have your voice. Maybe there's a problem with your cable connection, microphone technical problem.
And
okay, I think she has some
I think
problem.
she's typing. She's typing her question.
Okay.
And I couldn't greet Professor Hebda. Just want to say hello, Professor Hebda, if you have my voice. And yeah, thank you all for your time, energy, effort. Dr. Delavari, are you typing your question?
Okay, I think she can't.
If your answer is yes, please just pull down your heads.
Yes.
I mean, show a sign that's we're doing something. I cannot read your lips, but I cannot do lip syncing.
Okay, I think we can. We have not this chance to hear her voice. So please let us. Please let us take group photo. Then she can write the question in the chat box. Thank you, Dr. Delavari. Thank you.
Thank you, Dr. Delavari. That was so unfortunate. So, dear attendees, please turn on your cameras. We want to take a group photo. We want to take a group photo. Please make it fast. And who's taking the group photo, Dr. Darvish?
Mrs. Sadeghi, our very active appraised team from International Affairs of TUMS. Thank you, and our colleagues in Appraise to Raise team also.
Dr. Delavari, just please do not turn off your camera. We want to take a photo. Just, yeah. Stay there just for a minute. And Dr. Delavari, I think, just turned off her camera.
Thank you very much, all of you. Thank you.
Thank you, Mrs. Sadeghi. Thank you so much for staying with us and supporting technical issues. Okay, I think.
Do we have the photo? Is it done?
Yes.
Yes.
All right, then. I hope that all of the attendees could find this session useful. I wish you luck, happiness, success, and I want you to take care of yourself. Goodbye. Goodbye, everyone. Goodbye.
Goodbye, everyone. Goodbye. Thank you.